So we're talking about long COVID today. Just a little bit of background before we get started. We're 4 years into the global pandemic. And while we're not seeing the number of infections, hospitalizations, deaths that we were at the beginning, we're now confronting another issue in long COVID. It's left millions around the world with this syndrome. It's a constellation of post-acute and long-term adverse health effects caused by infection. And we know a couple of ways that seem to help prevent it, people from getting it. Vaccination can reduce your chances of getting long COVID by 15 to 75%, mean of 40%. And antivirals also have been shown, if administered at the correct time during the acute infection, to reduce the chances of developing the long COVID. However, reinfection now is the most common form of COVID because I believe the estimates are 97% of people have at least some immunity to the virus due to vaccination and or natural infection. And we know that reinfection can trigger de novo long COVID or exacerbate existing disease. And we also know that each reinfection increases your chances of getting long COVID. There are discussions about what the future would hold. This is a lot of people who have this constellation of symptoms, and there are going to be effects on the healthcare system, on the economy as people are unable to work, go on disability. We don't know the effect on children who have long-term COVID. And there is also some concern, we have no data yet, that we know with the 1918 influenza, with polio, with Epstein-Barr virus, that you can have sequelae decades, multiple decades after the initial infection. And we don't know whether that's going to happen with COVID or not. So this seminar today is, as I said, of a lot of interest because many people either have long COVID or know of somebody who do. So before we get started, let me do a little bit of introduction of TEPI and some housekeeping. We are the Texas Epidemic Public Health Institute. Our mission is to keep Texans safe and the economy strong by strengthening capacity and resiliency of Texas to respond to future infectious disease outbreaks. We hope we won't have another pandemic soon, but we will at some point have another pandemic, unfortunately. It's a state agency, however, it is housed within UTHealth, and a lot of our focus is establishing partnerships so that we can work together to satisfy our mission. I want to tell you about some of our training highlights. We have a pandemic preparedness and response certificate program. These are 4 asynchronous, totally online, free if you're a Texas resident courses to help you be better prepared, to assist, to help yourself during the next outbreak. And we also offer continuing education credits. There's a QR code there and a website address where you can go to sign up for these courses if you're interested. We also have some mini courses. These are 1 to 3 hour courses in special topics such as One Health, data visualization, which is using EpiInfo if you're an epidemiologist and familiar with that. We have one on risk communication and one on public health ethics. 2 more are going to be debuting shortly on advanced Excel and on financial management. So you can find those at the same site. There you go. These slides will be available if you can't write this down fast enough and are interested in those links. So if you, again, some housekeeping, if you're interested in live transcript, click on that closed captioning. There's a Q&A spot where you can ask a question. We will have a survey at the end of the webinar, so you can tell us your thoughts. And if you think there are ways we can improve these webinars, we would like to hear it. As I mentioned, the webinar is being recorded. It will get mailed to you. And you can also see previous webinars at that gouth.edu address. And I realize I always do this. I forgot to introduce myself. I'm Dr. Kathy Troisi. I'm here on the faculty at UTHealth School of Public Health, and I am the person who coordinates these Grand Rounds lectures. So our speakers today, I think I have another, oh yes. Our speakers today are Dr. Luis Ostrosky-Zeichner. He is a professor of medicine and epidemiology and chief division of infectious diseases at the at Herman Hospital. And he received, let me get a drink. The pollen counts, if you're not in Houston, are off the chart these last few weeks. He received his medical degree from Universidad Nacional Autónoma de Mexico, completed his internal medicine residency in Instituto Nacional de Ciencias Médicas y Nutrición Salvador Zuberon, and his infectious disease fellowship at UTHealth Science Center at Houston and MD Anderson in a combined program. As I mentioned, he's currently a professor of medicine and epidemiology and the Memorial Herman Endowed Chair at UTHealth Houston. And he is the vice chair of medicine for healthcare quality and division chief at the Division of Infectious Diseases. And if that wasn't enough, he's also chief epidemiology officer for Memorial Hermann Healthcare System. He's consulted with the FDA and CDC. He's published over 200 peer-reviewed articles, and his research interests are in medical mycology, transplant infectious diseases, healthcare epidemiology, and antimicrobial stewardship. And I have to interject here that he is going to be our speaker on May 8th, 4 o'clock Central Time, on fungal diseases. So we will welcome him back then. Our second speaker is Dr. Michaela Sandoval. She is a newly appointed assistant professor in the Department of Epidemiology and the Center for Infectious Diseases here at UTHealth Houston School of Public Health. And her research interests include the clinical epidemiology of infectious diseases with a special focus in health disparities in global health. So with all of that, John, Dr. Ostrosky, would you like to tell us a little bit about long COVID? And I'm going to stop sharing.
Thank you so much for the very kind introduction and the invitation to share some of our experience with long COVID. Fascinating disease. And I'm not really gonna have slides. I'm just gonna be doing a narrative of what we see here at our Center of Excellence, the COVID-19 Center of Excellence that Dr. Colazurdo, our president, had the vision to start back in the summer of 2020. This is, basically in June, July of the first year of the pandemic, we realized that there were patients being discharged from the hospital that were having chronic issues related to both the hospitalization itself, but also some unexplained findings that were not clearly sort of attributed to an ICU stay or the ventilator that they were on. And we quickly realized that we needed a place to see these patients for this new syndrome that was coined back then, PASC, post-acute sequelae of COVID. Since then, we've seen over 1,300 patients in my clinic at the COVID Center of Excellence. And the way we structured this Center of Excellence was to really follow the mission of McGovern Medical School, which is not only clinical care, but education and research and community service. So in this clinic, we decided to have a multidisciplinary model where a group of specialists is working together with the common goal of helping our patients find out what's going on with them and help them recover through this process. Our clinic is a standalone clinic. We have 4 rooms. We have dedicated staff that has over the years specialized in this area. We are integrated by a receptionist, a nurse practitioner, and then we have the specialist. We have a specialist in physical medicine and rehabilitation. We have a couple of pulmonary doctors. We have a psychiatrist. We have a rheumatologist, a cardiologist, a neurologist, ENT as well, and myself for infectious diseases. And our process is really one of us does the intake of the patient according to the cluster of symptoms that they're having, whether it's more respiratory or general or more fatigue. And once we do an initial evaluation of the patient, then we start sort of referring and counter-referring within the specialist represented in the COVID Center of Excellence. Over time, we have really found that long COVID or PASC is really a syndrome that is really integrated by multiple causes and multiple diseases. So it's not a true entity, but more of a syndrome. And we've found that our patients in the clinic come with one of three sort of patterns. I've identified these patterns over time. Pattern one are people that had most likely severe COVID and they ended up in the hospital. But sometimes these are people that are not hospitalized and are ambulatory, and they end up with end organ damage from the disease itself or the acute illness. And what we do is we really document this end organ damage and help people rehab through that. So examples would be pulmonary fibrosis directly from pulmonary injury or myocarditis from the COVID itself, blood clots. COVID-19 is a very sort of embolic kind of disease where we have a lot of blood clots and emboli going on. And basically, again, what we do is we document this end organ damage and we help people rehab through that through our different specialties. The second pattern is very interesting. These are people that, whether they know it or don't, have an underlying disease. And COVID itself, being a highly inflammatory and high sort of insult on the organism, triggers an exacerbation of this underlying disease or makes it present. It sort of pushes the patient over the edge where we finally make the diagnosis. So in our COVID Center of Excellence, we've diagnosed a lot of cases of new onset diabetes, new rheumatic diseases that were kind of in the verge of presenting, thyroid issues, anemia from other causes, etc. And again, it's really interesting to think whether this was truly an exacerbation by COVID itself, or if we're finding this because we're looking, because we do a very thorough assessment of the patient and, hey, we found you have arthritis and you didn't know, and this is what's giving you the fatigue. And again, what we do is we find this underlying diseases and we cure them and help the patient rehab through those. And finally, the third pattern, which is the more interesting one, is the true long COVID. And this is where people fall that don't fall in category 1 or category 2. And the thinking right now of the pathogenesis of long COVID is that it's either a persistent viral infection, kind of a low-level smoldering viral infection that creates all this fatigue and cytokines and just a persistent inflammatory state, or that it is actually a persistent immune dysfunction. The virus is gone, but the immune system is really not reset to the set point where it was before. So that's kind of the thinking of true long COVID. The good news about true long COVID is that for the most part, I would say about 90% of the time, patients get better on their own within 4 to 6 months. And all we do for them is supportive care, treating symptoms, and helping him, again, rehab through the process. And most of our patients do very well within 4 to 6 months. There are about 10% of them that continue to have symptoms. And again, we continue to support them throughout the course of the illness. There's another illness that we see in our clinic that's fascinating, which is actually chronic COVID. These are very, very reliably people who have lymphoma or other cancers, or they're undergoing therapy for autoimmune diseases with B-cell blockers, particularly rituximab, which is a very common medication for autoimmune disease and some cancers. And these patients basically have no B cells, and they can actually develop chronic infection with COVID-19, where the virus is actively replicating in the lungs and the upper respiratory tract. And these patients are very sick. They continue to progress to pulmonary injury, fibrosis, oxygen dependent. And we've been able to document a few of these cases, treat them with combination therapy for COVID-19 with remdesivir and Paxlovid. And when we had antibodies, we would use that as well. And we've been able to recover some of these patients, completely clear the virus, they get off oxygen. And my favorite story is this patient that sent me a picture mountain biking after seeing them in the hospital, on oxygen to go to the bathroom. That was their status. So very fascinating subset of patients that we see there. What do we do for these patients? It's really mostly supportive care. We really work with them on fatigue. There's some pharmacological therapy for fatigue. There's some rehabilitation that you can undergo with physical therapy or occupational therapy. We manage gastrointestinal symptoms that are very frequent in these patients that have sort of a slow GI transit, so we speed it up. We do a lot of cognitive interventions, sort of retraining the brain to think adequately and build up stamina for reading and paying attention to things, etc., because neurological complications are very common as well. We do a lot of cardiac rehab as well, where we do see a lot of our patients have POTS, postural hypertension, and we sort of manage that pharmacologically and help people deal with this episode of hypertension and autonomic sort of instability. So this is, again, one of the very common things. And our cardiology partners are completely sort of in tune into working with these patients. The other thing is that we are a very holistic clinic. We believe that there's a very deep connection between mind and body. And about 50% of our patients test positive for depression or anxiety when we do scales for those things. So there's a very strong component of psychiatric illness in our patients. And what we discuss with them is that we get into this very bad cycle of feeling bad physically, exacerbating depression and anxiety, and depression and anxiety exacerbate physical symptoms. So you get into this loop. And again, we have been able to get with our psychiatry partners and break this cycle. So we're very, very fortunate to have partners in the psychiatry department that help us with this patient. Another sort of breakthrough that we had is this is when telemedicine was in its infancy here in UTHealth, and the pandemic really precipitated this generational change, I would call it, to telemedicine. So we utilize telemedicine very effectively in the COVID Center of Excellence. After the initial evaluation in patient in person, we're able to do the follow-ups. We like to follow up with our patients along the way by telemedicine, a quick visit, 15 minutes to check on people and see if the medications they're using are helping, or discuss a test that came back positive, etc. Very convenient. And telemedicine has also allowed us to deal with acute COVID patients. So again, not only do we see long COVID, but we do have both our long COVID patients that have reinfections or new cases from the community we're able to handle through telemedicine very, very effectively. We have on-site testing capabilities. We have a PCR set up at the centers, so we're always able to make diagnosis on the spot. And finally, we do have a research mission in the COVID Center of Excellence, and we're sort of taking baby steps. We started with chart reviews of our own experience, looking at, for example, pulmonary complications. And we just did a really neat study with one of our medical students looking at ANAs, anti-nuclear antibodies, which are very frequently seen in this state. And we found out that they don't really mean that you have an autoimmune disease, and we don't really do much about it anymore. We've done small clinical trials looking at interventions like metformin, stellate ganglion blocking, which is kind of a way to regulate the autonomic nervous system. And again, we're able to do small sort of case series and try new interventions in our patients. And most recently, we were selected by the NIH to be a Recover site. The Recover platform is a very important platform that initially was collecting just data and samples to define what long COVID is and look for markers for this disease. But now it's interventional. So we're participating in a clinical trial called Recover Vital, which is a platform trial with different pharmacological interventions. The current intervention is a long course of Paxlovid, 15 days versus placebo, to see if it improves long COVID symptoms. We have the Recover Neuro trial, which is a neurocognitive study, where again, we do a baseline neurocognitive evaluation and then do certain neurocognitive interventions like little computer games and memory sort of work, etc., to see if those improve the neurocognitive deficits that these patients have. And most recently, we're going to start the Recover Energize study, which is really neat. It's a exercise intervention study to see if exercise in different formats improves or worsens long COVID. So we're very excited about our clinic. We're very excited. We have some philanthropic donors that are participating in this. We're really appreciative of this. The vision of the university and setting this up. This is one of the few long COVID centers in the state of Texas. And we're very, very excited to now be working with NIH in the interventional studies. So that's us in a nutshell. And I guess we can take a few questions, or do you want to leave kind of questions to the end?
How about if I ask you two questions that have come in?
Perfect.
One is, how does long COVID differ from other post-viral syndromes? Is it really new or another manifestation of what we've seen after past viral epidemics? And along those same lines, are there common points with other dysautonomias, chronic diseases like Lyme disease?
Yeah, so as it turns out, this is very likely a post-viral syndrome like we've known for ages. There's a post-viral syndrome related to Epstein-Barr, chronic fatigue. It's along those lines. There's a post-flu, or they call it now long flu as well. I think the difference is those diseases were relatively rare, and we have sort of very little knowledge about those. Very few people would really seek attention after an illness like that. And with the pandemic, we all of a sudden had, millions of people being exposed to the same virus, and the volume of people presenting at the same time made us realize this new entity. But I do believe that this is probably similar to other post-viral illnesses, although there are some clues that COVID is different, and COVID is more of a vascular disease that may be explaining some of these findings. As to the relationship to other chronic conditions like chronic fatigue or Lyme disease, again, we don't have a great understanding of those diseases. There's a lot of overlap also with psychiatric illness in those states, and I think we're really trying to tease out what's really infectious, what's inflammatory, and what's really neuropsychiatric at this point. But I do think that this is a fascinating area to study.
And one quick question, are low-dose steroids commonly given for long COVID symptoms?
We tried steroids initially during our launch, thinking again that this is kind of an inflammatory state. So we would do Medrol dose packs, which are short courses of high steroids that really taper over time. And we abandoned that practice because we really didn't see any benefit to our patients.
All right, thank you. We may have time for some more at the end. Dr. Sandoval.
Hi, everybody. My name is Dr. Kayla Sandoval, and I'm an assistant professor in the Department of Epidemiology and then the Center of Infectious Disease here at SPH. And let me get my slides together real quick. See what y'all can see.
Yes, we can.
All right. Are y'all seeing the pretty version or the?
We're seeing the pretty version, but we're also seeing the next slide if you want that.
Okay. Let me switch it up then. Let's do this one. Pretty version?
Pretty version, no next slide.
Excellent. So I'm also a member of TEFI. I do some surveillance work within that program. And today I'm going to be presenting preliminary results from the Harris Cares Embrace Hope Long COVID study, which was a partnership between UTHealth SPH and Harris County Public Health. So long COVID emerges as a significant public health issue, with some studies estimating as many as 1 in 10 adults in the US experiencing at least one long COVID symptom since the start of the pandemic. And while public health authorities were able to track acute COVID infections and short-term outcomes such as hospitalization and death, surveillance for long COVID is much more difficult. So people experiencing long COVID or post-COVID symptoms may not be recognized as long COVID cases, and patients who do seek treatment for post-COVID symptoms may receive care outside of the healthcare system where they were originally treated for COVID. So it can be very difficult to track patients longitudinally or to estimate the true prevalence of long COVID in a specific population. So to address these limitations, we leverage Greater Houston Health Connect, which is a large regional electronic health record-based health information exchange to investigate long COVID in Harris County specifically. So to do this work, we first created a customized cohort of Harris County COVID cases identified from electronic health records and from public health reporting. And we utilized the existing Southeast Texas COVID cohort, which is about 1.2 million patients with either a COVID diagnosis, lab test, or public health report across Southeast Texas, and that includes the Beaumont, Houston, Galveston, and Corpus areas. So for this analysis, we identified Harris County residents within that cohort who had been identified as COVID cases between February 1st, 2020 and June 1st, 2023. And then we developed a study-specific EHR-based long COVID definition based on the published literature and clinical expertise that we had on our team, and we classified patients as long COVID cases within our cohort. And the primary goal of this analysis was to identify clinical and sociodemographic risk factors for long COVID among Harris County residents and compare to existing data. And we also kind of wanted to explore the relationship between social determinants of health and healthcare utilization patterns among long COVID patients. And this is ongoing work. So these are preliminary results, but we are still working on this project, and we will be for the next few months. So our main data source is the Greater Houston Health Connect Regional Health Information Exchange. We also refer to these as HIEs, and like all HIEs, GHH collects and collates electronic health record data directly from healthcare providers, and they organize and sort of link up patient-level health records to give patients and clinicians a more complete picture of their medical history, including treatments, healthcare utilization, encounters across different healthcare systems, and such. And the primary objective of any HIE is to facilitate clinical care. But because these are extremely large, longitudinal, individual level data sets, they are increasingly being used for research in Texas and across the country. So just some caveats about this data. Participation in the HIE is voluntary in Texas, so not all providers in the area contribute data. They collect prospective and retrospective health data from about 15 million unique patients. They've got hospitals, ambulatory practices, community health centers, local health departments. But in Harris County specifically, they receive data mostly from hospital systems, community health centers, outpatient clinics, and then the City of Houston Health Department. Harris County Public Health did not contribute COVID data to this data set. And the major advantage of utilizing a health information exchange data set like this is the ability to track patients longitudinally as they seek care across different health systems. So if you're showing up to hospital A, receiving some amount of treatment, being discharged, and the next day you're showing up at emergency room B at a different hospital system, I can see that, which is a major step forward in clinical epidemiology research using this sort of EHR-based data sets. So, as I'm sure you've come to these conclusions based on Dr. Ostrosky's talk, but the study of long COVID within the EHR has unique challenges. So, as we all know, COVID case reporting has changed over time. Beginning in the spring of about 2022, COVID case reporting declined significantly as at-home testing became more widely available. So then the proportion of cases captured by the EHR and public health registries has decreased over time. And we have some idea of the true prevalence of COVID in some areas from environmental measures like wastewater monitoring programs, but individual level case reporting is no longer reliable. And likewise, the incident COVID cases we do capture are more likely to be severe enough for people to seek medical care, or they tend to be in people who are screened regularly, such as pregnant people or healthcare workers. But while COVID case reporting has gone down, long COVID case reporting is on the rise. So due to the complex nature of these sort of post-acute syndromes, long COVID was not immediately recognized as a clinical syndrome, and the definition has changed wildly over time. And while there are some clinical standards like the Delphi consensus definition and the CDC definitions, identifying long COVID cases across the pandemic and beyond is super challenging. Patients who exhibit symptoms that would now be considered long COVID may not have been documented consistently across the first 2 years of the pandemic. So because of these sort of intersecting case capture trends, we do not feel that we are able to temporally link a specific COVID-19 episode to a long COVID episode. And so we can't point to the specific COVID infection that triggered the development of long COVID symptoms. And we can't estimate the effect of especially later variants like post-spring 2022 on long COVID incidence. But we feel like we can explore the cumulative effect of COVID infection and look at clinical and sociodemographic risk factors. So, when we started this project, we first identified 444,777 adult Harris County residents who had been identified as a COVID case between February of 2020 and June of 2023. And those patients altogether make up the Harris County COVID cohort. It's going to get a little bit complicated, so bear with me. I'm going to say all these words many times. We then chose to determine long COVID case status by querying for 4 codes in the diagnostic realm of the EHR. So we had 2 SNOMED codes and 2 ICD codes because providers at different institutions use different coding systems, ICD, SNOMED, etc. So we want to note that the 2 SNOMED codes and the U099 ICD code were officially released for use in early 2021. So we wanted to include the less specific B94.8 code to capture some of those cases that were identified before the definition was solidified. So we know from literature that B94.8 was used by some clinicians to classify patients with lingering symptoms after COVID from literature. So as we started conducting these queries for long COVID diagnoses, it became clear that not all of our long COVID patients were in the COVID cohort. And so we hypothesized that some patients may have had COVID episodes that were not captured in the EHR, either because they were reported to a public health agency that was not a member of GHH, so there was just a loss in capture of that data, or because they were identified via an at-home test and they were never captured anywhere. So we did a little branch point here. We made the decision to search for long COVID diagnoses, both inside the Harris County COVID cohort and separately in the total population of Harris County residents with GHH records. So we conducted these two parallel analyses looking at long COVID cases within Harris County COVID cohort, as well as those patients that were captured in the general GHH population. They're still Harris County residents, but we didn't differentiate based on whether or not we had an original COVID case reported. So we collected, within the cohort study, we collected baseline characteristics at the date of first COVID infection. That was the entry point to our cohort, in addition to sociodemographic factors. And we were able to characterize specific COVID episodes within this cohort and then sort of track people over time up until the end of the study period or until they had a long COVID diagnosis. In the second study, which I'm going to call the prevalence study, whether or not it's a prevalence study, you can argue with me, but I'm going to call this prevalence study because that's too many words. We collected cross-sectional data on all long COVID cases at the time of their first long COVID diagnosis. So it's a much more limited data set. We don't have non-cases or controls, but the denominator would instead be the population of Harris County. And we were able to just kind of describe the demographic characteristics of these long COVID cases and compare them to the Harris County general population. And we also kind of looked into what kind of healthcare provider provided that initial long COVID diagnosis as a window into their experience. How did they come to this diagnosis? So starting with the prevalence study, since it's much more limited, remember that these are people that had long COVID or were diagnosed with long COVID between February 1st, 2020 and September 15th, 2023, regardless of whether we captured an original COVID episode. So identified about 6,000 adult residents of Harris County with a long COVID diagnosis. And we have a histogram and a map here. You can see the sort of slow increase of diagnoses across 2021, followed by peaks in early spring 2022, fall 2022, and summer 2023. And then this is a map that shows the relative density of patients with a long COVID diagnosis, just so you can see sort of approximately where our patients are coming from within Harris County. And that's based on the patient's residential address captured on the date of the data poll, which was September 15th, 2023. And so this kernel density analysis is not population-based and should only be interpreted as a relative measure. It just identifies areas with higher density of patients relative to the case population as a whole. It's not based on the population of Harris County at all. So we did not analyze children under 18 in any of our studies because we have poor capture of this population. And we wanted to concentrate on adults specifically. We examined the initial diagnostic encounters for all of these cases, and we found that 50% received their long COVID diagnosis from an outpatient clinic or primary care provider. 20% received their diagnosis from an encounter with a physician organization, and 30% received their diagnosis from a hospital system, which included both inpatient encounters, emergency room visits, and outpatient clinics. And so we kind of think that specialist providers like outpatient cardiology, neurology, immunology clinics would probably be in the physician organization or hospital system categories. It kind of depends on the provider themselves and how they're sort of financially attached to an institution, how that would show up in our data. So we compared our case population to the 2022 American Community Survey 5-year estimates for Harris County. And our long COVID patients were older, more likely to be female, and more likely to be non-Hispanic white compared to the population of Harris County. none of that is super surprising to me, but we will talk a lot more about those categories here in a minute. Okay, so shifting gears to our cohort study. This is our meat of our project. We identified that 434,777 adult COVID cases, and we followed them longitudinally to determine if they were diagnosed with long COVID between their first COVID episode reported and June 1st, 2023. So we excluded 114 patients who had a long COVID diagnosis reported before their first COVID. So if they had long COVID first and then COVID, we excluded them. And within the entire Harris County COVID cohort, we had 4,117 cases of long COVID identified. You're not going to see that on here because we further refined the cohort to create an analytic cohort to support statistical analyses. And we'll talk a little bit more about the decisions that led us to this analytic cohort. But the end result was 299,620 COVID patients, of whom 3,169 eventually reported a long COVID diagnosis. So, as we discussed, COVID infection reporting and capture declined sharply in 2022. And since we could not link a specific COVID infection to a long COVID event, we considered the first COVID infection report to be the entry point to the cohort. Unfortunately, this led to varying observation time between patients, which complicated our modeling strategy. So in response to those threats, we excluded patients whose first COVID diagnosis was within a year of the study end. So we excluded 55,577 patients who were first diagnosed with COVID between June 1st, 2022 and June 1st, 2023. The whole last year we just took out. Made sure that every patient was observed for at least 1 year. And so by excluding these patients, we also lessened the selection bias from the declining capture of COVID cases in that same time period. And another challenge that we encountered was high missingness in demographic and clinical variables. Because this is an EHR-based cohort, we have more information about people who interact more with the healthcare system. It's kind of a information trend that is a little unfortunate, but a feature of all EHR-based work. And so people with missing race ethnicity data were younger, had lower socioeconomic status, had lower comorbidity burden, and were more likely to have been identified as a COVID case through a public health registry rather than going to a doctor. And this missingness is kind of a common problem among population-based COVID surveillance studies, and just because public health authorities were not able to capture race and ethnicity data from all COVID cases. The hospitals are much more likely to capture race ethnicity than the public health departments, unfortunately. So to address these concerns, we excluded patients with a missing race ethnicity data and conducted age stratified analyses. So because age was the major variable associated with missing race ethnicity information, we stratified our models to more directly compare people with similar risk of having had that data missing. So it's a little unfortunate, but we had a difficult choice, and this is what we did. So for all of our models, we included demographic variables, including age, sex, and race ethnicity. We also included neighborhood level socioeconomic indicators, such as the social vulnerability index and the area deprivation index. We measured comorbidity burden with the Charleston Comorbidity Index, and we split COVID infection history into individual binary variables by epidemic peak. So for example, a patient with a reported COVID infection during the first wave, which was February 1st, 2020 to September 15th, 2020, would be considered a yes for that wave, regardless of whether they had any other infections in other waves. So each wave was considered a separate binary variable. And unfortunately, vaccination data is not well captured in the EHR, and so we were unable to include vaccination data in these analyses. So we had two distinct modeling strategies. The first model was more detailed exploration of specific comorbidities and measures of social vulnerability. And we did an age stratified modeling system for this one. And it allowed us to mitigate some of the bias caused by excluding the race ethnicity data and examine the relationship of specific risk factors within and between age groups. And our second model focused more on socio-demographic risk factors and prioritized a more nuanced view of risk among different populations. This one we use summary variables, a little bit more of a limited data set, and stratified by social vulnerability index quartile. So we really compared the least vulnerable quartile to the fourth most vulnerable quartile. And this model, because we had both age and comorbidity burden, we did test an interaction term between those variables. Okay, this is a terrible slide and I apologize. I'm going to tell you about it in words so you don't have to read all of these numbers. So these are only the significant variables from model 1, which was the age stratified model. We presented adjusted odds ratios at 95% confidence intervals. So interesting findings, race ethnicity was only a significant risk factor in the younger age groups, so 18 to 29 and 30 to 49. But the categories that showed up were different between those two groups. Both of them had, so 1829 had non-Hispanic Black and non-Hispanic other less likely to receive a long COVID diagnosis compared to non-Hispanic white, whereas in the 30 to 49-year-olds, it was non-Hispanic Asians less likely compared to non-Hispanic white. In all models, except for 18 to 29-year-olds, female sex had about a 1.3 times risk of long COVID diagnosis, which is very interesting. And I think one of our most significant findings here is that COVID infection during the Delta, which is the June 2021 to November 2021, and Omicron, which is November 21 to June 2022, waves produce a much stronger effect size than infections during the first and second waves. So these are considered independently. You can be in multiple waves, but any COVID infection in those waves was significant. And this is a dose response that we observed across all models and across all strata, suggesting a strong association with long COVID diagnosis. It's really interesting that the trend goes the same way in all of our models, where it's coming up on the pre-Delta, then goes up to Delta, and then comes back a little bit to Omicron. Which is very interesting. So we have some of the comorbid conditions that were recorded before the first COVID infection. And we see some trends, but different things show up as significant in different age categories, probably because the prevalence changes across those age categories. So for example, the peripheral vascular disease confidence interval for the 18 to 29-year-olds is absurd, because the prevalence of peripheral vascular disease in these young people is so low. But some things that showed up quite a bit were chronic pulmonary disease, peripheral vascular disease, diabetes, and rheumatic diseases. Very interestingly, social vulnerability really did not show up in these models. The only time it shows up is in 30 to 49-year-olds, where it's the theme 1, which is socioeconomic status, the 4th and 5th quintiles, which are the most disadvantaged categories of that theme, were less likely to have long COVID versus the least disadvantaged. But it really doesn't show up in any of the other strata. So I'm not going to spend any time on these forest plots. I'm just putting it there because I know that this is going to be released after. So feel free to peruse these forest plots on your own. And this is just social vulnerability showing that, my goodness, it's not significant. In the second model, we use summary measures of SVI and comorbidity burden. We stratify by the quartile of a social vulnerability index. And so we examine a little bit more nuanced relationships between the social determinants of health and long COVID. So we additionally tested the interaction term between age and comorbidity burden as categorical variables. but it was not significant in any of our models. So we are presenting only the main effects model to preserve interpretability of these results. So among the most and least disadvantaged populations, increasing age was similarly significant. However, the effect size trend was a little bit steeper in the most disadvantaged population. And likewise, female patients show up the exact same way they did in the other model, right around that 1.3 greater odds of receiving a long COVID diagnosis compared to male patients. Again, race kind of disappears in these models. Once you stratify out by social vulnerability, we really don't see race showing up very much at all. And we observed the same dose response trend for a COVID infection during Delta and Omicron, with Delta again showing that very high effect size, especially in the most disadvantaged population. So while we saw increasing comorbidity burden categories as significant across our models, the effect size did not just exhibit a clear trend. So among the least disadvantaged population, severe comorbidity had a similar adjusted odds ratio. It's not up here, but it's 1.49 with a confidence interval of 0.89 to 2.47. So it wasn't significant, but the effect size was similar. So it probably has something to do with the lower prevalence of severe comorbidity in that population. But I think that the most important takeaways here so far are that Delta wave being a little bit scary, and then the slightly different effect sizes across these two populations of least disadvantaged and most disadvantaged SVI quartiles. Okay, once again, just the forest plots. I just want to show y'all the this is Delta out here. Remember, this is a binary variable, Delta or no Delta infection, with the most disadvantaged just being way out past the first quartile, but both of them really sort of outstripping the other waves. So we observed a lot of things. I'm sorry I had to go through this so quickly. We saw clinical risk factors that make sense to us. We saw older age, female sex, and some of these pre-existing chronic diseases. These are probably true sort of biological risk factors for developing long COVID. But then we also saw sort of another set of factors which are probably more indicative of what it takes to receive a long COVID diagnosis. How do you navigate the healthcare system from the start of experiencing post-COVID symptoms to receiving a documented official long COVID diagnosis in Harris County? And so I think that there's two stories here. There's a clinical story and there's a socio-demographic story. And I think they are competing a little bit, where we're more likely to see older patients, sure, but we're also more likely to see non-Hispanic white patients showing up as having that long COVID diagnosis, which is unlikely to be biological in origin. However, having had COVID during the Delta or Omicron epidemic waves was strongly associated with eventually having a long COVID diagnosis, sort of regardless of all these other things, which is very interesting. And I think sort of the future of this work is expanding the cascade of care for long COVID. It's World TB Day, so I'm feeling in a cascade of care mood, but really looking at, from the population at risk, people who have had COVID, which is almost everybody at this point, how do we screen, diagnose, initiate people into care, treat them, and then support them through recovery. Who makes it to each stage, and how do we support people who need care getting care? And I just want to, I know I've got 1 minute, acknowledge the team. So Joshana Marco was our PI on this project, and we had a lot of support from our colleagues at GHH. Jenny and Janaid, I think, are on here. We had funding for the original Southeast Texas cohort study from the Cullen Foundation, the Cullen Trust for Healthcare, the Elkins Foundation, and the John P. McGovern Foundation. And then our partners at Harris County Public Health, who have been instrumental in shaping this analysis. I did want to put on here, this is also on our website, but the Harris County Public Health Department has put together a long COVID self-reporting platform, and that is this green QR code. So if you or your patients are experiencing post-COVID symptoms and would like to report those to the county for surveillance purposes, you follow this QR code. Once these slides are available, this is also a link. So if you don't do QR codes, you can click the link. And then I also wanted to share that we have TEFI resources for long COVID, including literature and some lists of clinics around Texas. So if you are a clinician looking to refer somebody, or you're a patient looking to find a long COVID clinic near you, this is the second dinosaur QR code. I don't know why Google insisted on putting a dinosaur in my QR code, but that is also a link that you can press. I also have like 20 supplemental figures that will be available in the PDF version of this presentation. But if you want to do a very quick question.
Sounds like people are ready to go home and have dinner. Thank you both, Dr. Ostrosky, Dr. Sandoval, for this really interesting talk about an topic we're going to be hearing more about, I'm afraid, in the future. As Dr. Sandoval mentioned, there are resources on the TEFI website, so check it out. Also, on the TEFI website, you can sign up for our Lit Rep newspaper. It comes out once or twice a week with, we scan the literature about COVID and other infectious diseases that have outbreak potential. And there are always articles about long COVID in that. So again, free, thanks to the state of Texas. So thank you all very much. And we will see you, I hope, on May 8th for Dr. Ostrosky again, talking about fungal diseases. I'm blanking on the name of that TV show because I haven't watched it. All of Us? I can't remember. But
The Last of Us.
The Last of Us, thank you.
Yeah.
I did hear a fascinating talk at an emerging infectious diseases conference about how we all should be worried about fungi. So please join us on February 8th. And again, that sign up information will be on the TEFI website. Thank you all very much for joining us. Bye-bye.